So as a conclusion, this particular integrative protocol could increase the quality of sleep of cancer patients receiving cancer chemotherapy, and this modified the dosage of hypnotics and antipsychotics being used by them. And this particular research work, it can contribute as an evidence-based documentation in the field of integrative research in medical oncology. And the future prospects, a randomized control trial can be done on the same topic and adding as placebo as separate group, and also another pharmacodynamic studies can also be done to know the mode of actions. Then comparative study of the same protocol with the scalp cooling can also be done to know about the which one is the better and less expensive for these patients. So these are my references, and thank you.
This study was conducted at AHMA hospital.
Yes, sir.
This is a modern hospital, isn't it?
Yes, sir.
Did you get the consent from the patient and the oncologist?
Yes, sir. Before preparing the methodology, we had a meeting with the oncology head HOD, and we actually I stayed there for 2 weeks to know which is the very prevalent problem faced by the patients receiving the chemotherapy. So I personally, for that 2 weeks, I personally talked with every patient receiving chemotherapy. So this particular, there were many conditions, but this particular insomnia, even though they thought it is there when receiving chemotherapy. So they don't feel like telling as a separate problem, but even if they tell, there is no much options to cure that insomnia. Even the oncologist they are treating also will tell, like that they were telling the patients. So the patients never told they had insomnia. So when I started, every patient in a day, if 120 patients are receiving chemotherapy, that 120 patients will be suffering from chemotherapy from insomnia for the next 14 days. That was the prevalence. So we addressed that. We, in the sense, me and my department addressed the problem and a possible solution to the HOD. So they told to apply for the CTRI registration, and ethical committee and CTRI was done, and thus we got the permission to do.
Okay.
It's an add-on therapy.
Yes, sir.
So what was their therapy in this case?
The patients were given solpidem 5 mg for 14 days.
So the issue is in the trial as well as the control group, both the medicines were same.
Yes, sir.
Medicines were same. It is meant for sedation.
Solpidem is given to increase the sleeping time and reduce the sleep latency. Sleep latency in the sense reduce the time taken to fall asleep. But the half-life period, based on the half-life period, the working of the solpidem is only for 2 to 3 hours. 2 to 3 hours they will continue. So in the control group, we observed that, and whereas in the study group, when our Ayurvedic intervention was also given, the sleep was maintained to 8 to 9 hours per day. Even when on the day of the chemotherapy happens.
So in your result, in your discussion, the difference means that is more than half, or the double the percentage was shown in this.
It's 40% and 7%. Quality of sleep, about the quality of sleep.
But it is a common practice. In our practice also we are doing that, but we didn't get that much result. That is why I am asking, this much difference has been noticed or not?
Yes, sir. Difference was noticed. So in my discussion, I was proposing that it might be due to an integrative effect. So the action of solpidem will be fixed, and pharmacodynamic studies are there stating the mode of action. So whatever which were contributed apart from that, solpidem might be because of our integrative therapy, and at present we have applied for a pharmacodynamic study, in vitro study in the same cell line, and we are about to find the mode of action based on this. Whatever this Ayurveda intervention can contribute apart from the solpidem.
Thank you.
Thank you, sir.
And what is the duration of Panabhinga and Talam?
Every day 7 p.m. to 7:30 p.m. 7:30 p.m. The time was fixed on the idea that 2 hours before the actual sleep time.
What about the stress factor present?
For every patient, stress was variable, and actually we didn't taken that stress factor into account of this study. Every patient had that stress, financial stress, everything. Fear of that disease, whether they will live for more than 3 months, like that. Every patient had such type of concerns.
Okay, doctor, it was a great presentation. So the duration of the study you mentioned was 14 days. You observed them for 14 days and collected data, right?
Yes, sir.
Okay.
The Pittsburgh Sleep Quality Index was taken after 1 month.
Okay, that's what I wanted to ask whether there was a follow-up for each cases.
14 days, yes, up to 3 cycles I was there for every patient, but it is not documented. But clinically, they demanded less for solpidem further. They didn't want solpidem. Usually, when chemotherapy is given, they will ask for, I have this complaint, I want this medicine, I am having a gastritic problem, I want this medicine. But in these study group patients, they didn't demand for solpidem in further studies.
So that means there was a sustainable impact.
Yes, yes. After 3 cycles I was there. After that, that follow-up was not taken.
Okay, thank you.
Thank you, sir.
You mentioned Qutipin. What is Qutipin?
Qutipin was a solpidem. Qutipin and solpidem. Qutipin is antipsychotic drug. Solpidem is non-benzodiazepine. Currently, both are used in combination to that regulate the stress factor. But in my study, all the control patients and all the study patients were given only solpidem.
Okay.
Thank you, ma'am. Thank you, everyone.
Please bring that slide changer, please. Slide changer. Next contestant 5.
A very good afternoon to the distinguished guests and honorable judges. Today I am here to shed some light on the condition that affects millions of lives worldwide, rheumatoid arthritis. Let's take a step back in time and reflect on the history of this debilitating disease. In the past, rheumatoid arthritis used to be a mysterious event, often misunderstood and misdiagnosed. It used to be a silent tormentor, silently wreaking havoc in the joints. This picture dated back is of 1841 to 1919, is of an impressionist painter, Sir Pierre Auguste Renoir. He was probably one among the very few patients who were first diagnosed with RA. The disabilities at the hands are evident. However, the times have changed and so is our understanding of RA in the past 13 decades. Today we are armed with advanced diagnostic techniques and innovative treatment options. We have made remarkable strides in the management of RA. But RA continues to cast its shadow in the lives of millions of people. As per World Health Organization, a staggering 18 million people are suffering from RA and 13 million of them are experiencing the severity level. Let's have a glance at these graphs. As per the Bayesian age period cohort analysis, the incidence begins from the 5th year of age till the 54 years and the maximum disability between 50 to 60 years. And also, as per the age standardized incident rate, in females it is going to increase by 18.23% and in males by 8.4% by 2030, which is not so far. So these analytical reports, they serve as a wake-up call, emphasizing an urgency to address the global burden of rheumatoid arthritis. Now let's understand the etiopathogenesis. Etiologies, the updated ones are classified in 3 different phases. Phase 1 is at risk. There is an intricate interplay between the genetics and the environmental factor, but this occurs in initiating the autoimmunity, propagation and onset of the disease. But this occurs very early in life, potentially as early as in the prenatal development. Even the fetal exposure to smoke imposes a risk factor for the RA. Second is the preclinical stage. There has to be a triggering factor. It can be either dietary, it can be lifestyle, or it can be hormonal factor. It enters the sea, orchestrating a symphony of complex interactions. It is because of that the mucosal surfaces, they provide the site for amplification of the citrullinated proteins. And thirdly is the symptomatic of the clinical RA. It is at this stage that the immune system itself takes the spotlight. It becomes a double-edged sword, both as a protector and a perpetrator, unleashing barrage of destructive forces on the delicate side of you. And therefore, the rheumatoid arthritis can be best characterized as an immune-mediated inflammatory disease that once initiated, even though the putative trigger has been removed, feed-forward pathway result in an auto-perpetuating process. Now let's understand the pathogenesis of RA in 4 distinct stages. The first one is triggering stage. We said that there is an intricate interplay between the genetics and the environmental factor. It leads to the formation of ACPAs, which go and activate the major histocompatibility class 2, which activates the T cells, T cell activates the B cells, and again the B cells leads to the production of ACPAs. So this triggering stage is sparks. It fans the flames of inflammation. It awakens the immune system from the slumber and sets the wheel of rheumatoid arthritis in motion. Once the triggering subsides, the maturation takes place. There is a continuous co-stimulation of the cytokines and the macrophages. Ladies and gentlemen, let me tell you, these macrophages are the master orchestrators causing major effector damage in RA. Then comes the targeting stage. The small joints of the hands and feet are targeted because of the unique anatomy. The joint extracellular matrix along with a crowd of immune cells leads to increased cell adhesion. There is increased angiogenesis which leads to edema. Within the edema, there is increased osteoclastogenesis which leads to bone resorption. It creates bare area of resorption from where the deformity arises. And next, the fulminant stage arrives in a crescendo in a symphony. Because of the dysregulation of the synoviocytes, there is a hyperplastic synovium which perpetuates the joint destruction. And that is, in entire scenario, we can say that the triggering stage, it ignites the flame, maturation sharpens the immune system, targeting directs the azole, and fulminant marks the pinnacle of the disease activity. Now let's understand RA from Ayurveda point of view. We know Vada Rakta is a Vada Vyadhi Prabheda, where there is an amalgamation of Vada and Rakta. Now tracing the Vyadhi Samprapti, it is evident that after the Nidana Sevana, the dose travels from the Koshta to the Shakha, they get lodged in the targeted area, small joints of the hand. It is the place where the Shuddha Rakta is converted into Ashuddha Rakta. The Shuddha Rakta loses its Laghutvam and Saratvam. It becomes Guru and get accumulated in the bare areas, leading to deformity. So, to break the chain of Samprapti, our stalwarts have given 3 major strategies, that is Virechana, Vasti and Shodhana, apart from the Agni Deepana Amapasha that is already set. So, going through lots of research paper like Front, PubMed and Springer regarding the gut clearance or gut cleansing, I learned that the timely correction of gut dysbiosis helps in reinstating the blood-brain barrier by brain homeostasis, activates the inflammasome, reduces the lipid peroxidation and enhances the antigen processing. This is very much correlatable to the gunas of Shodhana mentioned in our classics as Buddhi Prasadam, Roga Haratvam, Kaya Agnibir Vardate. And that is why Shodhana is very much beneficial in any of the Sandarpana Janivadi, and Vada Rakta is no exception. Next is the bloodletting. It used to be the first line of treatment many years ago. You can see in the picture of a metacarpophalangeal joint, the blood cells are penetrating inside the bone through the bone resorption areas, creating to deformity. So once we do the Rakta Mokshana, we reduce the shear stress on the endothelial wall and we get rid of the joint from the accumulated Ashuddha Rakta. Next, coming to the third part of my presentation, I am introduce a potent combination of 2 single drugs. One is Mundiliga Churna and Guduchi as the Anupana of this drug. The title of the thesis is Effect of Mundiliga Churna with Guduchi Koada Anupana in Vada Rakta with special reference to rheumatoid arthritis. Now, Mundiliga is the principal drugs for Arthas indicus and Guduchi is Agroshada of Vada Rakta Distinguiscura cordifolia. Both of them are having Lagu Guna, which probably must have combated the Guru Guna of the Ashuddha Rakta and provided with the promising results. So this combination, apart from that, Mundiliga Churna is a potent analgesic, it is a potent anti-inflammatory and a potent mast cell stabilizer. And about Guduchi, we are very much familiar how it acts as a potent anti-inflammatory for the Vata Rakta conditions. So after administering this intervention in 22 patients for 30 days duration, we got promising results, especially in the anti-CCP titer value, which reduced from 81.8 to 18.2%. Also, there was significant reduction in the ESR, CRP and RA factor, and the disease activity also reduced significantly. At the last, I would like to acknowledge the contributions of modern medicine since they have got plethora of interventions from the steroid to the monoclonal antibodies. But the goal of any system of medicine has to be to reduce the disease activity by rendering safe medications and to prolong the disease remission, which is not achieved yet. So this is not a rabbit versus turtle game of modern medicine versus alternative medicine. We together must extend our boundaries of understanding this complex disease and forge a pathway to find a brighter future to combat this disease. Thank you. Towards the last, since the time permits, I would like to place on record a deep sense of gratitude to my department teachers for the constant support and guidance. And also, I'm very much thankful and indebted to AHMA 2024 for providing this phenomenal platform to be able to share my novel understanding on rheumatoid arthritis and the study drug with the scientific community. Thank you so much.
Next 11.
You have tried this Meditica Choma.
Yes, sir.
What is from where the textual reference can you elaborate?
Thank you, sir, for the question. This reference is taken from Chakradatta in Vadarakta Chikitsa Prakarana. Lidva Mundi Tigadau Madhu Sarpi Samagritam. Guduchi quadra is to be taken Anupana. Vadarakta Sudusturam. So it is Hapusha only, sir, which is given as AHMA Vadahara Hapusha Diya Bravasti we give. So this is a potent analgesic as well as mast cell stabilizer. So these single drugs were selected in an aim that it will be providing a potent Rakta Prasadana, Rakta Shodhana and also Anulomana.
What was the dose? Churna.
Churna, it was 6 gram BD. So in one day it is 12 gram, 1 karsha.
This drug is superior than Amrita.
Pardon, sir? Munditiga is?
Superior than this Amrita.
Thank you, sir, for the question. Now, Guduchi itself alone can do all these actions, but Munditiga together had potentiated the action of Rakta Prasadana also because it is a potential analgesic also. That study was conducted in the Raviguna department from our college, keeping an analgesiometer with a diclofenac as a comparison drug. And it proved that Munditiga is a potent analgesic also, but I think Guduchi is not a potent analgesic, it is anti-inflammatory above and all. So this combination together potentiated the mode of action of both the drugs together.
What kind of rectamosh are you advised in this case?
Thank you, sir, for the question. Sir, it depends. Like if it is Desha Majid Sarvam, we can do Prachanam. If it is localized, we can have this Jaluga Ucharna also. So variety of cases that come to our OPD, if it is localized in the leg only, then we can give Jaluga Ucharnam. Otherwise, we go for Prachana also if more of the skin conditions are affected. So taken into that consideration of which place and how much is the affected areas, we can select whatever the Rakta Moksha entities in that.
Thank you.
Thank you, sir.
You have considered ACCP levels for evaluation. Then what about ESR and CRP, other indicators, inflammatory indicators?
Thank you, ma'am, for the question. I have also included ESR, CRP, RA, and also calculated disease activity rate. But I have just highlighted anti-CCP because there are no Ayurveda papers which are doing this research on pre and post anti-CCP values because the anti-CCP test itself is very cost effective. It is very costly for any patient to take the pre and post interventions. And very few, around 3 to 4 only allopathic medication, allopathic research papers are available in the modern fraternity regarding this anti-CCP levels. They do it only for the confirmatory level. But once we get this anti-CCP level reduced or back to zero, it will be a breakthrough in reducing this disease activity and curing diseases like rheumatoid arthritis or any autoimmune disease spectrum.
In this study, it come to zero level.
No, ma'am, from 81.2, it reduced to 18.2, 81 to 18.2. We got a drastic change, and also we have followed up the patient. There was no increment in their anti-CCP values. Like the mark is 270, 20 to 200. So we had patients who had 1,500, who had 500 and more. So it reduced to 100, reduced to 150, and it has not again aggravated even after stopping this course of treatment. After this OP treatment, the patients were followed up in the IP. They were given this Shodhana like Virejina and Vasti, Gobilaksha Kasha, and everything was done. And again, one anti-CCP was done to see whether their levels are increasing or not, but it maintained the levels.
Then what was the duration of the study?
It was 30 days, ma'am.
Okay, thank you.
Thank you so
for
much.
the nice presentation.
Thanks.
Number 11.
Good afternoon all. Today I am here with my presentation titled on the topic Management of Fistula in Ayurveda and Advanced Sharasutra Technique, that is IFTAR. Interception of the fistula tract with the application of Sharasutra. It is a case report. Then moving on the introduction of the topic. Then moving on the introduction of the topic.
proceed.
Please excuse the time.
Then moving on the introduction of the topic. As we all know, fistula in the ano is an abnormal communication between the two epithelial surfaces. The tract is usually lined by unhealthy damaged tissue. And the main cause of the condition is infection, cryptogrammalar infection of anal fluids. As we know, fistula in the ano is the most notorious condition among the anorectal diseases since antiquity. The perianal abscess and fistula in the ano represents a same acute and chronic condition, same condition of the same disease process of infective origin. Perianal abscess, the condition of the prevalence of the fistula in ano is about 26 to 38%. The prevalence rate of fistula in ano in India is about uncertain, and in a case study it showed that the prevalence rate is about 8.6 cases per 1 lakh population. The disease is 4 times more common in males as compared to that of females, and the average affected population is about 38.6 years. Even though the disease is not a life-threatening condition, it produces severe inconvenience in our routine life due to the severe pain and discomfort the patient complains. According to signs and symptoms, the conditions of fistula in ano can be correlated to Bhagandara in our Ayurveda classics. The Bhagandara is considered among one of the Ashtamahagadas rogas, that is the diseases which are difficult to cure. There are various treatment modalities edited for the treatment of Bhagandara in our Ayurveda classics, and Sharasutra is one among them, which is proved to be a gold standard among them.